Right. Well, welcome again to our SIREN series for social care researchers. The series explores social care relevant research methods that may be known to some, may be very new to others, and as always, methods that we are eager to learn more about from our colleagues. I am Danielle Hessler-Jones, one of the co-directors of SIREN, and I am delighted to introduce my friends and colleagues from the Oregon Health and Science University, or OHSU, Miguel Marino and Jorge Kaufmann as our speakers today. Dr. Marino maintains a broad statistical research program at OHSU in the Department of Family Medicine that focuses at the intersection of primary care and public health studies. His research utilizes novel statistical methodology to address complexities associated with the use of electronic health records for critical community and primary care research questions in health policy, health disparities, preventive service utilization, health insurance monitoring, among others. He is currently funded by several agencies, including NIH, AHRQ, and CDC, and has over 200 peer-reviewed publications, is director of the Primary Care Latino Equity Research, or PRIMER Center, the statistical editor for JAMA Health, co-chair of the NIH Community Engagement Alliance Needs and Assessment Evaluation Network, and on the National Advisory Committee for Racial, Ethnic, and Other Populations in the Census Bureau. In 2002, he was elected as a member to the National Academy of Medicine. Jorge Kaufmann is a biostatistician in the same department at OHSU. Driven to improve person and population level health, he utilizes electronic health records and survey data to help identify disparities in healthcare utilization, delivery, and outcomes, as well as the effects of health policy and program implementation. His analytic work is enhanced by his history of teaching medical sciences, as well as prior clinical work as a naturopathic physician. Curiosity, methodology, and communication are the central tenets that guide his approach. Today, Miguel and Jorge will be speaking about considerations and the use of different quantitative approaches to evaluate natural social care experiments. There's growing interest in natural experiments, which can assess the impacts of interventions, policies, or initiatives, including circumstances when controlled experimental research designs may not be feasible or inappropriate to implement. I have had the pleasure of learning a great deal from the two of you over the last few years, and so grateful for you both joining us here today. Before I turn things over to our amazing colleagues, I just wanted to give you a quick heads up on the logistics today. We're going to hear from our amazing speakers and with some reserved time at the end for Q&A discussion. So we're going to ask that everyone keep yourselves muted throughout the presentation portion and use the chat function for your questions. We'll then, at the end of the presentation, have a moderated Q&A going through the chat questions, as well as then inviting you to raise your hand to ask questions live. The webinar will be recorded, and the recording will be available on our SIREN site and sent to you via email as well. And as always, please do share your ideas for future methods conversations at siren@ucsf.edu. And with that, it is my pleasure to hand over the virtual mic to Miguel and Jorge. Thank you so much.
Thank you. Let me just get my stuff situated here. So one clarification, I was not elected to the National Academy of Medicine in 2002. It was 2022. In 2002, I was still struggling in college, so definitely would have not made it then. But thanks for the introduction. I want to just sort of take a little moment here just to thank for the work that SIREN folks have been doing, and really want to have a conversation about evaluating social care natural experiments with my colleague Jorge Kaufmann. And so we wanted to start today's methods conversation with an outline of what we want to present. So methods for natural experiments are pretty broad, and current methods are continually being updated, and just new methods pop up every week, it seems like. So we want to spend, we could have spent a whole year, we could have had to spend a whole series on this, on talking about every method and the nuances of each of those approaches. But given that we only have a little under an hour, we thought it would be wise to provide a quick overall general picture of different types of methods, and then really focus on a recent development that is motivated by a pragmatic study that Jorge and I are currently working on with our colleagues at UCSF and OCHSU. And so first, we'll provide a few definitions that are relevant to natural experiments. We'll provide an overview of common methods with some examples in the published literature. We'll again talk about the pragmatic study that is motivating some of the work that we've been doing, and show a little bit or at least hint at some recent developments with time varying start times. And by that, we mean sort of when interventions start at different time points. And then I sort of took a step back and thought about, so what are some future potential in natural experiments? I sort of outlined some of those. And just generally speaking, all right, so hopefully this talk will motivate you to think about some of these. What's a checklist that you can sort of use broadly again when you're designing an analysis for a natural experiment? Okay, so for context, I think we're all here because in one way or another, we believe in a research mission very similar to the SIREN mission of improving health and health equity by advancing high quality research on healthcare sector strategies to improve social care. And so social interventions are essential to reduce health inequities and tackle other health priorities, but they're always not amenable to experimental manipulation. And so what do I mean by experimental manipulation? So suppose you know, or you want to know, the impact of an intervention on a particular health outcome. So in a perfect world with unlimited resources, where we, the researcher, had all the control, I think we could come up with a rigorous randomized trial to answer this question. So as we know, randomized trials are the gold standard for evaluating the effectiveness of interventions. And there are several pros and cons to randomized trials, with a lot more pros than cons, I believe. But one pro that I really want to highlight is that randomization of units guarantees that on average, so sort of large sample, big sample scale, that on average, that there should be no systematic differences in unobserved and observed confounders. So even things you can measure and things you can't measure, that the randomization sort of guarantees on average that those differences in observed and unobserved confounders between units that were assigned to intervention and units that were assigned to control, that they should balance out. They should sort of be no systematic difference, so that you can then causally attribute effects of that intervention to your outcome of interest. However, not in all interventions in social care settings are able to be evaluated through randomized trials for a variety of reasons. And so in most settings, we're actually in a setting depicted in this figure where the element of randomization is non-existent. So in this scenario, you may still have people who were exposed to an intervention and some that were not, and you could still follow them to see if they developed good or bad outcomes. But we, the investigators, have no control over who got the intervention or who got the control. So the setting of natural experiments lives in this space. And so what is a natural experiment? A natural experiment is any event not under the control of a researcher that divides the population into exposed and unexposed groups, or to an intervention group and a control group. And so natural experiment studies use this naturally occurring event and the variation in exposure to identify the impact of that event on some particular health outcome. And so whereas randomization guarantees that on average, there is no systematic difference in observed and unobserved confounders between intervention and control groups. So one key consideration is that in natural experiments, there is a selective exposure to the intervention. And this selective exposure likely leads exposed people to differ from those who were unexposed in characteristics that are likely associated with the health outcome of interest. And so this is a huge consideration that must be accounted for in methods that evaluate natural experiments. And so before we move forward with methods and sort of examples, I did want to take a minute to situate natural experiments with other types of experimental designs. So when we think about different experimental types, we typically start here on the left. And so looking here on the left, so what degree does the investigator have over the intervention assignment? And sort of generically, or in sort of the most basic form, there's two possibilities. So the first is the intervention status is assigned by the investigators, or it occurs naturally or not influenced by the investigators. And so suppose you're a clinic director, a clinical director overseeing multiple primary care clinics, and you are interested in evaluating the effect of an intervention on say, cancer screenings. So if you are that director, you then have the ability to then assign which clinics get the intervention and which don't as part of a rigorous study design. And because you have the power to assign clinics to interventions, you may then say, well, I want to randomize some clinics to intervention and some to control. And so that type of study design where the intervention is randomized is what you know as the randomized control trial. Alternatively, if let's say again, you're still the clinical director, and instead of saying that you're going to randomize, you say that you're going to give the intervention only to clinics with less than 5 clinicians on staff, and control clinics will be larger clinics with more than 5 clinicians on staff, right? So it's not a randomization, but there is some sort of criteria, and in that scenario, no randomization is performed, and we say that the intervention is exogenous. And so when you're in this setting, you typically call this a quasi-experiment. So the investigator may have some control over who gets in the intervention through an exogenous factor and not randomization. So then going back down here, in most settings, the investigator has no influence as to who gets the intervention. So if an external factor, for example, a Supreme Court decision that allows states to expand Medicaid or not, then the result is that results in some units being exposed and some not. And in this scenario, we say that the intervention is exogenous. And this is what we call a natural experiment. And then lastly, when an intervention is self-selected, then that is typically an observational study. Though in practice, you can make the argument that these are all observational studies because you are following people or units or clinics or hospitals over time. But the point here is that natural experiments are a result of intervention status being influenced not by investigators, but by another external factor. Okay. So with sort of that setting, now let's dig into some methods. So the simplest and probably most common method used to analyze natural experiments are difference in difference approaches. So in its most basic form, this approach compares changes in an outcome among people who were exposed to the intervention with changes among people who were never exposed to the intervention. And although there are several ways to estimate this change, typically the intervention effect is estimated from a regression. And you have sort of in its most basic form, again, 3 components. You have a term for intervention group, so like a yes, no, or intervention control indicator. You have a period, again, in its most basic form, it's a pre-post period, pre-intervention, post-intervention, and then you have the group by period interaction. And so then the coefficient of the interaction term is the difference in difference estimator. That's sort of thinking sort of more in the weeds, but what I really want to talk about is sort of give a little more intuition about the difference in difference approach. And so intuitively, the difference in difference approach relies on a very strong assumption of parallel trends, sort of highlighted here in this figure, which says that in the absence of intervention, the pre-intervention trends would have continued for both groups, right? So it would have continued. In this scenario, they were both going up, and the parallel trend says this would have continued. And so how this works is that if you have an intervention and control group, it's okay, or they may differ at the level. So this little gap here is consistent, and that's okay, because what we're really interested in is this trend over time. And so what you want to see in a difference in difference analysis is that this trend over time are parallel prior to the intervention start. So if you then make the assumption that pre-intervention trends would have continued in the absence of intervention, then you could take the difference within intervention group. So here B minus A, this is the program, this is the intervention group. If you take that difference, and then you take the difference within the control group, here D minus C, then the difference between those differences gives you the estimated intervention effect. And so in its most basic form, this is what it's doing. It's essentially following this pre-trend and evaluating the difference within groups, and that's how you get the difference in difference approach. And there are several hundreds of examples of difference in different studies, many of which come from economic literature, but they are definitely used in population health and health services research studies as well. And so here are two examples to illustrate the flexibility of difference in difference approaches. So this first study here on the left is a study by Vasson and colleagues, where they evaluated a natural experiment in the Special Supplement Nutrition Program for Women, Infants, and Children, also known as WIC. And they noted that in sort of, I think it was middle of 2021, 9 states required WIC beneficiaries to either mail or present these cards in person at their local WIC office every 3 to 4 months to reload their benefits. And again, this was during the pandemic. So this was sort of an in-person re-up. And so what you have here then, it becomes a very clear natural experiments of states that allowed online reloading of EBT cards and those that did not. So you had 9 states that you had to be present, and then the rest of the states could have done it virtually. And so then using difference in difference methods, the authors found that offline, so sort of the in-person EBT reloading system was associated with significant relative decreases in WIC participation during the pandemic. And that was mostly driven by increased WIC participation in online states. So the participation went up in the states that had online option, and it actually decreased WIC participation in the offline states. So in another study here on the right, my colleagues and I leveraged the natural experiment that resulted from the Supreme Court ruling that left the Affordable Care Act's Medicaid expansion intact, but it made the Medicaid expansion optional for states. So in this study, we assessed the changes in diabetes-related biomarkers. So specifically here, hemoglobin A1C. We looked at that 24 months pre-ACA, 24 months post-ACA, and we did that by race, ethnicity, and insurance group. And so then using difference in difference methods, we showed that although those who gained insurance through Medicaid expansion had improved HbA1c levels over the 2-year follow-up, this benefit differed across racial ethnic groups. So some did better than others. So along with difference in differences, you also have another method is the interrupted time series, and its analog, the comparative interrupted time series, which Jorge will talk about a little bit later. And this is also one of the most widely used natural experiment approaches. So an interrupted time series consists of a sequence of outcome data at evenly spaced time intervals. So you have these data points over time, and they're equally spaced. And then you typically then also have one well-defined change point. There can be others, but for the most part, the classic interrupted time series is there's one intervention time point, an event happened, and sort of that's your time marker. And that typically corresponds to the introduction of your event or the intervention. And so one of the appealing parts of the interrupted time series is that depending on how you set up your model, you can actually provide an estimate of the changes in the levels, or in other words, the immediate impact of your intervention on your outcome, and also simultaneously a change in the outcome trend associated with the intervention, controlling for what was happening prior to the intervention. So you're able to estimate a level change and then a change in the slope compared to what was happening prior to the intervention. So this is a really useful method with one sort of very key drawback is that it typically lacks statistical power. So the power depends on the expected intervention effect size. So and this one is a big one. So you probably would be able to find power, but it also depends on the degree of autocorrelation in the outcome over time. And so here are 2 examples of studies that utilize interrupted time series in different contexts. So the first is a study by White et al. That looked at the association of Texas' 2021 ban on abortion in early pregnancy with the number of facility-based abortions in Texas and then the surrounding states around Texas. So again, here we have a clear policy change that resulted in a natural experiment. And here what the authors found is that the Texas law banning abortion in early pregnancy was associated with a decrease in the total number of facility-based abortions among Texas residents. And so from the figure here, you can see that there was an immediate effect. So the level went down, and then the slopes pre and post aren't much different. So it was increasing slightly, it's increasing slightly, but the impact, the law had an immediate impact and sort of sustained similar trends as pre. In a different study here, utilizing interrupted time series, my colleagues and I wanted to evaluate whether the change in 2002 by the Association of American Medical Colleges that allowed applicants to choose more than just one racial identity led to a change in trends of applicants who self-reported as American Indian and Alaskan Native. And so what we found here was that changing the method of race ethnicity data collection did lead to an increase in more American Indian and Alaskan Native applicants, both initially, so there was a little bit of a level change, but also in the trend. So prior it was going down, and then the change went up again. So from this figure, you can see that the trend in the pre-application period was going down and then saw a reversal of this trend where it was increasing in the follow-up period. So the next method is the synthetic control approach, which has been around for a little over a decade. This method really came about as an answer to the big problem that one can encounter with the types of with other types of methods, and which is it's really hard to find controls that closely match the background trends and characteristics of the intervention group. And again, because we're not randomizing, the intervention and control group can be very, very different. And figures maybe like on the left, this one's not that egregious, but then you could have scenarios where there just would be no feasibility in trying to compare them. And so what synthetic controls do is it uses a synthetic combination of control observations rather than the observations themselves to serve as controls. So a synthetic control is basically what it does is looks at these observations and uses a weighted average of control observations to provide the best visual and statistical match to the intervention subjects on the pre-intervention outcome trends, and potentially also you can include predictors of the outcome. So the idea here is the treatment group has this level that's higher, maybe different slopes. You can come up with a weighted average of the control group to sort of get a really close approximation of a group that mimics the treatment arm. And so then here, the difference between, so once you do this, and if you do this well, then the difference between the post-intervention trend, so after the intervention, then that provides the estimate of the intervention effect. And then to get a p-value or so something like that, a statistical inference around that intervention effect is a bit complicated, and that does require approaches beyond conventional methods of statistical inference. So in this scenario, if you are interested in something like this, definitely work with your local statistician or economist or epidemiologist to do this. So again, going back to examples. So the first example we look at was actually the original study that proposed this method. So Abadi and colleagues wanted to estimate the effects of California's Proposition 99, which is a large-scale tobacco control program that California implemented in the late 1980s. And so the figure on the left shows per capita cigarette sales with California in the dashed line, and the rest of the US states in the solid line. And so as you can see, prior to the passage of Proposition 99, California trends in cigarette sales looked much different than the rest of the US. And so the figure on the right shows here, it shows the results from the synthetic control approach that produced a weighted average of the rest of the US states to estimate a synthetic control that looks nearly identical to California in the pre-proposition time period. And so the authors show that following Proposition 99, tobacco consumption drastically fell in California relative to the comparable states. And sorry, I meant California is this solid line. The dashed line is the rest of the US. And so the second study here on the right really wanted to answer the following question. So did the use of direct-acting antiviral hepatitis C medications change after these medications were carved out from Medicaid-managed care organization coverage and finance fee-for-service in 4 state Medicaid programs? And so then using synthetic controls as depicted in these 4 figures, so one for each state, they showed that carve-outs of hepatitis C medications from Medicaid managed care organization coverage may actually increase access to these medications, potentially improving the health of Medicaid enrollees with hepatitis C. Right, the next natural experiment approach is something I'm sure everyone's heard of, but we'll nevertheless cover it briefly. So these are instrumental variable methods. So these methods address the issue of selective exposure to the intervention. Again, because it's selective because we're not randomly assigning people to intervention and control. And so it addresses this selection by replacing the confounded direct measure of exposure, in this case intervention. It does this by sort of replacing that measure with a unconfounded proxy measure called an instrument that's very similar to treatment assignment in randomized trials. So for this method to be valid, an instrumental variable must sort of meet 3 criteria. So first, it must be associated with the exposure to the intervention. So it must have this direct link to the intervention. The instrument must have no association with confounders, so there's no direct line here. And it must be associated with the outcome only through its association with the exposure. So there's no line connecting the instrument to the outcome. And so instrumental variables that satisfy these 3 criteria also, sort of the nice thing is that it addresses unobserved confounding, which is a nice thing that randomized trials get at, right? So they do balance unobserved confounders as well. And so estimating intervention effects in this scenario typically requires a 2-stage process. So generally speaking, first, you do a regression of the intervention variable on the instruments performed. And then you use those predicted values from that model, and then you replace the intervention variable on the outcome regression. So then the fitted values then sort of regress on your outcome, and that should give you hopefully is an unbiased estimate of the intervention effect. And so I will say that this approach is very appealing, especially because of that unmeasured confounding, how it addresses that. But it is very, very, very hard to find a good instrument in public health and in health services research. And so particularly meeting the last 2 criteria is very challenging. This criteria that an instrument is not related to a confounder and not related to the outcome. And so those are really, really challenging to identify, but there are some good examples. So I'll go through a couple. And so the first example is a study by Berkowitz et al. That evaluated whether participating in a medically tailored meal delivery program for medically and socially complex adults was associated with fewer inpatient admissions. And so the study used an instrumental variable approach where the instrument was the geographic distance between the community serving's single location and the centroid of an individual's zip code. So it uses this distance metric. And so then using this approach, they found that participation in a medically tailored meals program was associated with fewer hospital and skilled nursing admissions, and in general, less overall medical spending. And in the second study, this is a study my colleagues and I performed that leveraged the unique natural policy experiment in Oregon, where Oregon gave a subset of uninsured low-income adults access to Medicaid through a randomized selection process. So here, uninsured low-income Oregonian adults were encouraged to put their names on a reservation list, and the reservation list included more than 90,000 registrants. But of those 90,000, approximately 30,000 were randomly selected to apply, and then so there is a randomization component. And then, but not everyone got Medicaid. So only about 10,000 were ultimately enrolled. So it wasn't like a true randomized study because of sort of the compliance problem. And so our goal was really then to estimate the potential causal relationship between insurance coverage and the receipt of preventive services. So here, our instrument was randomization, and it was clearly associated with insurance because it gave some people insurance through that randomization lottery. It was also not associated with confounders because it was a random process, and it was associated with preventive services only through its association with gaining insurance. And so what we found then using the instrumental variable approach is that Medicaid coverage was positively associated with a host of different preventive screenings. So that covers that very, very broadly and pretty fast. So the most common methods for studying natural experiments. And I will want to reiterate, there's a lot of nuance and there's a lot of machinery behind these methods. But we thought presenting something more broadly would sort of hopefully pique your interest in doing a deeper dive in these methods. And for the most part, these methods are the bread and butter in natural experiment settings. So you can get by on these methods for the most part. And even just keeping it classic, just simple, you can do good work with those. But we know that in social care research, life isn't that straightforward, and tweaks to these methods do have to be performed to meet the reality of what's going on the ground. So on that note, I'm going to pass this on to my colleague Jorge, who will go into a couple of approaches that lead into a real-world example. And so you can see how messy these can get, and they get messy really fast, and why the field of natural experiment methods is exploding with new approaches. Jorge?
All right, awesome. Thanks, Miguel. All right, so we're going to set the stage by stating that a person's health is impacted by more than just the ability to pay for healthcare. Social risks, social determinants of health, such as food, housing, or transportation insecurity, each uniquely and or in combination impact quality of life and health outcomes. And because of this, there have been calls to integrate social needs assessment and hopefully resource provision into our healthcare models. And it's happening. SDH screening tools are being incorporated into EHR platforms. And so thinking caps in place, questions arise about how or will these tools be used, or whether there are ways to promote their long-term adoption. So using this framework, this motivating framework, we're gonna start with two didactic, simple natural experiment scenarios and finish off with a real-world example. Next slide. So in simple scenario number one, we have two clinics in which one begins to receive some type of support to do more SDH screening with their patients and one that does not. Imagine the support to be some kind of hands-on training or financial incentive. And there is a date that support begins on, and you, the research, have screening rate data for both clinics, both before and after the support is initiated. And you want to know, does the support affect some kind of change in screening rates? Next slide. So one approach might be to use a controlled pre-post design. And this would be appropriate if all you had was a single pre and post rate measurement for both clinics. In this depiction, the red dots represent your clinic receiving intervention. The blue dots are your control clinic. And the vertical dotted line is the date on which intervention begins. This scenario is somewhat less than ideal, however, because can you be sure that these data points are not outliers, for example? Next slide. Or yeah, good. Also, how can you infer about baseline or secular trends with just 4 points? With 2 data points per group, there really isn't much to go on to decide if it's reasonable to believe that the intervention clinic would have behaved like the control clinic, absent the support that it received. The larger time gap between pre and post measurements, the greater potential for unmeasured confounders and or variation over time. Next. In a similar scenario, you might only have access to an average screening rate for each clinic in each period. But because it still amounts to only 4 measurements in total, the same questions around the validity of your findings exist. Even if the means are an aggregate of a large time span, you have no information regarding variation or trends over time. Next. In either of these scenarios, you can get an estimate of the average treatment effect using the difference in differences estimation that Miguel introduced earlier. You can get an answer to your question, did the support affect some change in screening rates? But the validity of that estimate will be of concern. Still, this may be the best answer you can get if this is all the data you have. Next. Continuing to use our 2-clinic and 1-intervention research frame, a third scenario exists where you don't just have 4 screening rate measurements or 4 aggregate means, but have multiple measures over several time points for each clinic, both before and after the intervention start. And this would allow for the comparative interrupted time series design. Next. In this case, we can assess if intervention and control clinics are behaving similarly in the pre-period by checking if the baseline trends are parallel. And we can account for any secular trends that might include seasonal variation or other initiators of change in our outcome. Next. It is now also possible to compare slopes and estimate rates of change in SDH screening over time. Next. With multiple measures, we can also focus our research questions using time components. For example, we might hypothesize that an immediate increase in SDH screening will occur right as intervention starts. Next. There might be a lag time that you want to account for. Next. Or a cut point after which you want to see if there will or will not be a continuous and or sustained change in those screening rates. Next slide, please. Okay, so that was scenario 1, and you can go to the next slide. So a second scenario might present something like this. So there's a new state program aimed at increasing SDH screening. All clinics must enroll in the program, but have a year and a half to do so. Because of this, clinics are enrolling at different times. And since all clinics must eventually enroll within a relatively short period, one approach is to use clinics that are not yet enrolled, as opposed to never enrolled, as controls in order to generate the counterfactual for a difference in difference. And we can still ask, does the new program increase screening? Next slide. To do this, we can use an extension of the comparative interrupted time series called a multiple baseline design. And in this approach, it might be appropriate when a set of clinics all receive the same intervention, but at different times. And there was no randomization used to select who starts when. The various start times occurred naturally. With this setup, we can still assess and account for baseline and secular trends, examine immediate or sustained effects, and estimate an overall average treatment effect. Next. Also, if we observe a similar effect size at the different intervention start points, we can gain some confidence that the intervention and not some other confounder produced those results. On the contrary, if we have a large estimated average treatment effect, however, a large effect is only observed, say, when clinic 3 switches from intervention to control, and little or no effect is seen at the other transition points, we might question whether there was truly an effect caused by the intervention. So depending on what data you have, this may be a good and best approach to test your hypothesis. Next slide, please. All right, so let's get out from under the cozy didactic blankets and check out this real-world example. We'll call this the free-range organic all-natural experiment for now. So imagine there are 2 separate and distinct interventions co-occurring with the common goal of increasing SDH screening in the healthcare setting. There are 26 clinics receiving a comprehensive 6-month program of hands-on support for implementing EHR tools to social risk screen. These 26 were part of a standalone cluster randomized trial known as the ASCEND study, led by Dr. Rachel Gold and her team at OHSU. And at the same time, as part of the Accountable Health Communities, or AHC initiative, by the Centers for Medicare and Medicaid Services Innovation, 13 clinics receive financial incentives to boost SDH screening. Moreover, 7 of the Ascend and AHC clinics receive both the implementation support and the monetary incentives. The last piece of information here is that you have a large pool of potential clinics linked by a common EPIC-based EHR, clinics that did not receive either intervention. And voila, a natural experiment is hatched where we can ask, did either intervention work on its own or in combination? Yeah, so this particular natural experiment is formally known as the CRISP study, and it's led by Drs. Gottlieb, Hessler, and Ackerman here or there at UCSF, right? Next slide, please. So the aims, the red, yellow, and blue arrows in this image represent the main questions of this study. For the yellow arrows, did receiving any intervention versus none have an effect on SDH screening rates? For the blue and red arrows, did receiving 2 interventions result in a greater effect on screening rates than receiving only 1? Next slide. Before we can decide which study design or designs might help to answer our research questions, we need some more information. Next slide. So we have available to us monthly data to calculate SDH screening rates over a large time span, and this is good. There are 13 distinct intervention start dates for monetary or implementation support, the earliest of which is in September of 2018, the last being February 2021. There are 31 clinics that receive intervention, remember, so this must mean that some clinics share the same start date. Starting to sound a little less didactic. Next, also remember there are 7 clinics that received both interventions, neither one, AHC or Ascend, always starting first. So at this point, we'll grab a coffee and keep going and try to remind ourselves, what was it that we wanted to know? Next slide. So did either intervention work independently? Easily enough to find out about the Ascend clinics in their own step wedge cluster randomized trial. We point you to the published study results. To examine whether the AHC clinics benefited from financial incentives, one option is to use a similar study design as Ascend. Next, where clinics not yet treated act as the controls. However, next, please. Because clinic start times were not randomly assigned, we could use a multiple baseline comparison to estimate our average treatment effect instead of the cluster randomized step wedge used in Ascend. And this is a clean way to approach multiple start times with only one study group. Next slide. So to answer the question, did receiving any intervention compared to none result in increased SDH screening rates? We should start by selecting a group of control clinics that resemble the intervention clinics in ways that may influence screening rates. For CRISP, we matched clinics using 6-month baseline summary measures, including screening rate, total number of visits, distinct patients seen, also the percent of the patient population that was 18 and over, female, identified as Hispanic, non-Hispanic Black, preferred a spoken language other than English, utilized public insurance or were uninsured. Also, whether the clinic was located in a Medicaid expansion state, if it was a federally qualified health center, how long it had been active at the study start, urban versus rural location, and whether they had an on-site, they have on-site social services and a designated primary care facility. Next. So if all 31 intervention clinics began intervention on the same start date, then we would have the ingredients for a comparative interrupted time series to estimate slopes such as those depicted here in the red and blue. And we'd be able to obtain a valid, robust estimated average treatment effect with relative ease. Next slide. But this is CRISP, remember. So there isn't just one turn-on date in this study. There's 13. Next. We also have one group of control clinics and one any intervention group consisting of clinics receiving financial, implementation support, or both. So we can't use the multiple baseline comparison. Next. What would a difference in differences estimate look like in this case? There's no longer one pre-intervention period and one post-intervention period for difference in difference estimation. Now there are 13 different pre and post periods of varying lengths. But can you estimate an average treatment effect still? Yeah, the answer is yes, you can. For each time point you have data for, you could create an indicator for whether a clinic is in an intervention or control state. So the control clinics would be coded 0 the entire study. Then the intervention clinics will become a 1 at their intervention start through the rest of the study. You include this indicator, time, outcome measures, and a statistical model that you would normally use to estimate a difference in difference, and an average treatment effect can be generated. However, consider two things here. One, you're no longer comparing a group of intervention clinics to a group of control clinics only. You're now comparing clinics that have begun intervention to clinics that either will not or have not yet undergone intervention. And two, what about checking and accounting for parallel baseline trends? There are 13 baseline trends now, and some may be parallel, others not. So even if your favorite statistical software generated an estimate with a p-value, you could be answering a question that wasn't your initial intent with an answer that may not be very robust or valid. In short, for statistical reasons that require a more in-depth dive into something we can't go into today, a clear distinction between intervention and control, the ability to use a well-defined baseline period to adjust for group differences, and the ability to account for treatment group heterogeneity are all vital to average treatment effect estimation methods using difference in difference. Luckily, there are really smart people out there thinking about this and providing solutions to advance the field. Next, yeah. So Brantley Calloway and Pedro Santana are two such people. In this paper, they propose an approach to difference in differences that we can use in our CRISP study. Next, please. So now, each clinic that starts intervention at the same time constitutes a micro-intervention group with its own time since intervention and its own distinct pre-period and its own unique propensity score generated from the microgroup's pre-period data. And with this, an average treatment effect is estimated for each group time combination. In statistical terms, this means that you will have a very large number of coefficients, slope changes, level changes, that allow you to see the effect on each group time combination, and that can be aggregated into a single average treatment effect. In short, instead of using a model that spits out one difference in difference estimation for the entire study population, you generate as many difference in differences as you have group time combinations, allowing you to have and adjust for well-defined base periods and also account for treatment group heterogeneity. So thank you, Calloway and Santana. This is going to be really helpful. Next slide, please. So we plan to apply this Calloway-Santana estimator to also compare dual intervention clinics to single intervention clinics, in which case we have done some subsetting so that because we have 2 change points for one and 1 change point for another clinic, we now will use a pre-period in which they're both receiving the same intervention and a post-period where the additional intervention is initiated. So stay tuned for CRISP dissemination. And with that, I'm going to pass the virtual mic back over to Miguel to wrap things up.
Thanks, Jorge. I'm realizing we're a little past time. I want to make sure we have some time for questions, so I'll try to be brief here. So now sort of want to pivot to, so what are some future potentials in this space of natural experiments? And so what I presented was sort of really bread and butter methods for evaluating natural experiments. And I do want to reiterate, these still work, but as what you saw Jorge presented, these settings are complex, and with complexity comes the needs for layering of new methods on top of the bread and butter methods for natural experiments. So just wanted to point out that these kind of methods, like matching, like data weighing, things like falsification and placebo tests, are there to sort of help you really ramp up these methods so that you can address some of these complexities. And along with new methods, I think in the era of big data, we are starting to connect multi-level data sources across time, across geographic regions, across different populations. And so how do we utilize these novel data sources to really maximize its potential to evaluate natural experiments in real time? So sort of working in this space, it's frustrating that to see these natural experiments pop up and people really wanting answers to the impact of these events on health outcomes. And we just simply have to wait a long time because our data sources take forever to be available and processed. And if you're thinking about writing grants to evaluate these events, that takes a long time. And so how do we streamline this better to be able to answer these questions faster while still maintaining high quality rigor? So there's future potential there. I think another future potential in this space is the potential to increase the role of qualitative approaches to natural experiments. So there's a strong body of literature that has shown the immense value of qualitative research in strengthening the design and analysis of randomized trials of complex health interventions. And qualitative research undertaken in preparation for and in concurrently with natural experiments can really help identify which outcomes may change as a consequence of the intervention and what are the priorities for decision makers. I think qualitative methods could also help researchers improve their understanding of the complex process that underlies the intervention. It could also really help identify factors associated with intervention delivery and uptake, and highlight the pros and cons of the collected outcome measures and exposures. And so one of the things I'm also looking forward to in the CRISP study that Jorge presented is the planned qualitative and mixed methods approaches to examining how addressing social determinants of health impact providers and clinic culture, and how these contextual and provider factors impact the implementation and sustainability of these social determinants of health interventions. So I'd say that qualitative mixed methods work in natural experiments are rare, and the field of natural experiments would benefit from incorporating more of this kind of work. The last thing I sort of foresee is an opportunity to think about natural experiments in the context of a target trial. So for those of you who haven't heard too much about target trials, I'll provide a quick overview. So as we know, randomized trials are the preferred method for addressing causal questions about interventions. And so one can imagine a randomized trial that, if large enough and completed successfully, might answer those causal questions about interventions on health outcomes. And so that hypothetical trial is referred to as the target trial. So in practice, the target trial on, say, let's just say the effects of insurance on, again, preventive screenings, that may be infeasible and thus really not practical to carry out. So we must rely on this observational data to answer this, as we've sort of discussed a bit. And so this target trial emulation is this framework for drawing causal inference from observational studies. And as administrative data like electronic health records become a primary source for causal observational studies, there are several errors that people make that really invalidate those type of studies. So things like immortal time bias, residual confounding, et cetera, et cetera. So this approach really is like a checklist that helps us avoid making fundamental errors that can result in erroneous causal conclusions. It really helps us to take a step back and really formally think about this idea of a randomized trial. And so in the context of a natural experiment, I think what this would entail would be to say, you know what, I'm okay with moving forward and moving away from the typical pre-post design and parallel trends and thinking of time series. So a sort of in the future thinking about target trials more like, if I can think of, this natural event that created people, that moved people into intervention and control, maybe that then you can sort of force want to sort of condense this longitudinal data to a framework that looks a lot like a randomized trial. So we'll have strict inclusion-exclusion criteria, and for the most part, pre-intervention outcome may not come into play. And that may be okay, since sort of, again, randomized trial still follows patients prospectively, and you're still trying to get at causal estimates of the intervention. And so this is a fairly new framework that has gotten some traction, mostly in the field of pharmaceutical interventions, but in theory, again, sort of thinking in the future, it could really relate to the work we do with social care research. So here are a few papers that are useful to read if you're interested in this kind of work. And they really helped form this idea of maybe we can also push this or do this well with natural experiments. So the first on the top left is the primer on the framework by Miguel, and the bottom two showcase examples during the pandemic when we really needed to understand what treatments were working against COVID-19 while the RCTs were being conducted. And so this paper on the top right also just came out about a few months ago and asked the question, our database studies are explicitly designed to emulate past and ongoing randomized clinical trials of medications able to generate similar causal conclusions. And they found that yes, in this highly selected, non-representative sample, these real-world evidence studies can generate similar conclusions to randomized trials, but it actually is really, really hard to achieve. So this may be an area of opportunity. We'll skip this example here.
And thank you. So we are just about at the top of the hour. I want to thank both of you and acknowledge. Oh my gosh, there's such a wealth of information here. And sorry to cut us short.
No.
A little bit.
I was done.
There's a couple of questions for those who are able to hang on a couple minutes after the hour that I'd love to pose from the audience. One is, from Allison, what do you see out there in the literature around showing the value add? These are fantastic statistical procedures, but like you highlighted, they can be complex. Have you seen any literature that directly compares the added value of taking these steps?
Yeah, so I think one of my, I'll stop here. So it's rare for us to sort of know that this one method works best across all settings, nevertheless in particular settings. So I think what I would recommend as sort of, if you are thinking about using these methods for natural experiments, is to select one that you think probably fits best to your research question, but to consider other types of designs as sensitivity analysis to see how robust your method is to just different model specifications. So the studies that I see that are really, really good, they'll say, you know what, we'll do a difference in difference. And as a sensitivity analysis, we'll incorporate propensity score weighting, or we'll do an interrupted time series as well, just to see how robust the intervention, how robust the method is to just different specifications. So I would highly recommend picking one, but having others planned as sensitivity analysis, as highlighted here, number 8.
Fantastic. And sneaking one last question in before we wrap. If others with us today really wanted to learn more and have some primers, I know a couple slides back you showed us some great literature that was suggested that individuals could go to. Are there any other key articles or literature that we should take on as primers?
Oh yeah, that's a great question. I think generally the info is pretty dispersed, but if I can, I'll put on my company hat and I'll say JAMA has really nice methods briefs or introductions, methods primers that really are good ways to start thinking about this work. So I know there's primers on just in general natural experiments, primers on difference in difference, interrupted time series. So there's a lot of stuff being written in the medical literature now to try to bring people up to speed.
Fantastic. Thank you. Well, thank you all so much for joining us today. I know that I learned a ton. I hope that you did as well. And the recording of this will be available. So and looking forward to hopefully seeing you at future SIREN events. Thank you.
Thank you.